The mental and behavioral disorder IME, also called a psychiatric or a psychological IME, represents a specialized medical assessment. It's typically performed by a non-treating health professional and in a very specific context and arena with a very specific mandate. For example, to determine fitness to work, disability determination, causation analysis, or for some other indication. The IME is performed at the request of a third party, for example, an employer, a lawyer, or others, and it's not a service that is funded under provincial health benefit plans. The focus and circumstances for each IME vary widely and can be exceedingly complex. Unlike is the case in a clinical assessment or a treatment service delivery, there's no traditional physician-patient relationship or fiduciary relationship established. Despite the absence of a traditional physician-patient relationship, completion of an IME is considered the practice of medicine, and the same professional obligations apply as what would apply in the regular clinical patient care. The IME fundamentally differs from a clinical encounter, and it typically consists of a single encounter, done either in person or virtually, with no follow-up required. To avoid the so-called dual agency bias, the treating health professional should not perform an IME on a patient previously or currently under their care. There's an absence of a duty of care or a duty to advocate. When the examiner takes on a dual role, it results in an irreconcilable conflict of interest, and it potentially obfuscates the objectivity and impartiality required in the legal or administrative decision-making process. There's no single professional qualification, credential, or specialization or subspecialization, for example, forensic psychiatry, that's universally required to conduct an IME, and typically the examiner is required to have the requisite competence and hold a medical license in the relevant jurisdiction. There's a considerable variability in the quality of existing mental and behavioral disorder IMEs, which presents a challenge for the civil forensic psychiatric community, particularly regarding adherence to protocols and the quality of reports. To identify and develop practice guidelines, we performed a literature review using relevant databases, focusing on terms related to IMEs and mental health. We also developed a grading framework to provide guidance on the level of support for the different recommendations for the different components of the mental and behavioral disorder IME. So this grading framework is designed to facilitate the implementation of best practices and to improve reporting, quality, and the accuracy of these IMEs. After ruling out any conflict of interest, the examiner can opt to take on the assignment or not. A written service agreement between the requesting party and the mental and behavioral disorder IME provider is then executed. The examiner should receive relevant background information outlining the reason for the referral, as well as the very specific questions posed that need to be responded to following the completion of the IME. Typical IME questions include those pertaining to symptoms, the psychiatric history, the diagnosis, impairment, and very specifically capacity, risk, and tolerance in the occupational context. It also focuses on the basis for limitations and/or restrictions and the contribution of medical and non-medical factors. It also focuses on identifying the presence of workplace issues, the presence of malingering, personality traits or a personality disorder, cognitive deficits, the presence of substance-related conditions, or any other contributory physical conditions, and that would include medication use that may also be impairing. Further questions in an IME relate to functionality, past and future treatment, adherence to treatment recommendations, and finally prognosis. The examiner is expected to restrict their attention and later response to questions posed by the referring party. Prior to the assessment, the written consent must be obtained, and consent, of course, has to be voluntary, free of coercion, and it can be withdrawn at any time. It's important to ensure the examinee with a possible mental health disorder has the requisite capacity to engage in an IME. The assessment can be virtual, and that should be on a secure platform, of course, or in person, and a medical scribe or chaperone can be present, also with the examinee's consent. If consent is declined, the examiner should decide whether to proceed or not, and there may well exist a basis to not proceed. Involve third-party observers, for example, legal representatives, union members, a spouse, an advocate, or any other party not involved in the assessment is generally not permitted. Uninvolved third-party observers can be of benefit and are generally permissible, determined on individual merit. And these include, for example, a medical scribe or chaperone, psychometrician, interpreter, or a medical learner. Conducting recordings and having involved third-party observers can invalidate an IME, and these should only be permitted under exceptional circumstances or where it's actually mandated by law in the particular jurisdiction. An IME opinion relies on triangulating all available data sources, and it's constructed using standardized and reproducible methodology. There's reliance on multiple sources of information, both objective and subjective. We apply standards and current nomenclature and impairment rating as required by disability compensation and other relevant legislative schemes in the particular jurisdiction. Subjective sources of information include the psychiatric assessment, conducted with the necessary sensitivity, and it should include current and past injury, illness, birth and developmental history, adverse childhood experiences, social and family history, military history, occupational and environmental history, legal history, substance-related history, and activities of daily living are also captured. Further sources of subjective information include self-assessment questionnaires and psychiatric rating scales and screening tests, and these are completed at the instruction of or administered by an examiner to screen for psychiatric disorders and substance use disorders and symptoms, as well as for psychiatric impairment. There are numerous psychiatric rating scales available, many of which are non-proprietary and available in the public domain, and which can be used free of charge. Now, these scales generally lack validity parameters and are more subject to non-clinical factors' influence. The current DSM, that's the Diagnostic and Statistical Manual of Mental Disorders, diagnostic assessment protocol is not sufficiently objective, and hence the IME must include validity testing. To limit bias, the use of psychological instruments with validity testing is deemed a requirement in the completion of the mental and behavioral disorder IME. Now, these additional tests allow for symptom validity determination, detection of a response bias, assessment of examinee motivation, and confirmation of the diagnosis of cognitive and personality disorders. It's also aimed, importantly, at ruling out malingering. Numerous validity tests are available, and these are typically not in the public domain, and these require a purchase. Formal validity testing is an indispensable component of the IME, and yet it's often omitted in psychiatric IMEs. Further testing is also recommended as needed, for example, toxicology, diagnostic imaging, electrodiagnostics, and so forth. And these may be necessary based on the particular circumstances of the individual case. Collateral information must be sought from knowledgeable others as needed. Objective sources of data include clinical records, a review of pharmacology prescription profile databases, collateral information, the clinical assessment, the mental status examination, and toxicology or other testing, for example, a CT or thyroid function, etc. A mental status examination is performed, and that must include a description of the following domains: appearance and general behavior, motor activity, speech, language and communication, mood and affect, thoughts and perception, sensorium and cognition, judgment, insight, reliability of the individual as a historian, behavior, as well as safety risk. Now, a physical examination is not commonly required in the mental and behavioral disorder IME. Not all psychiatric disorders are in fact rateable. For those that are rateable, psychiatric impairment should be quantified. To do so, the American Medical Association's Guides to the Evaluation of Permanent Impairment supports the use of only two rating scales. One, the Brief Psychiatric Rating Scale, or the BPRS, and secondly, the Psychiatric Impairment Rating Scale, or the PIRS. The Global Assessment of Functioning, or the GAF, is no longer used. A confidential, objective, dispassionate, and respectful written report is compiled and submitted, capturing an opinion that must be non-partisan, fair, objective, and as unbiased as possible. And that should meet the legal standards in the particular jurisdiction. The mental and behavioral disorder IME opinion is strengthened by conducting a coherence analysis, as supported by the work of ACOM, or that's the American College of Occupational and Environmental Medicine, assessing continuity, consistency, congruence, compliance, causation, comorbidity, and culture, or the so-called 7 Cs. The opinion is often based on a balance of probabilities and with a reasonable degree of medical certainty used for decision-making by medical, administrative, or legal stakeholders. The IME report is submitted, fulfilling in good faith the required elements for the admission of expert evidence in the jurisdiction, and the examiner should state that they recognize their duty to fair, non-partisan, and objective assistance in the matter in which they are retained. Like any report generated following an IME, there may be limitations to the assessment, and the report should identify these. Examiner bias should be mitigated, and the examiner should aspire to the highest attainable ethical standards of civil forensic work, and these are outlined by the Canadian Academy of Psychiatry and the Law. The examiner should maintain a high degree of vigilance to meeting their duty to protect, their duty to report, as is required in the particular jurisdiction. The establishment of a clear grading framework for mental and behavioral disorder IMEs is expected to enhance the methodological rigor and to promote better integration of scientific findings into clinical practice. The findings from this paper establish foundational guidelines that can help legal, administrative, occupational, and clinical stakeholders engage more meaningfully in the process of performing the psychiatric IME. Implementing best practices is likely to result in an improved level of accuracy and reliability of medical examinations, ultimately influencing and optimizing decision-making in legal cases related to mental and behavioral disorders. This work provides an overview of an important framework that aims to standardize and enhance the process of psychiatric independent medical examinations. It also enhances the ability to cater to the evolving needs of stakeholders in this particular field. The authors of this work emphasize the necessity of sharing these particular best practices and standards within the wider occupational, legal, and medical community to elevate the overall standards for conducting psychiatric IMEs.